Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
All right, welcome back, everybody. It's been a minute since I've gotten to hang out with Mike alone. Thanks to all of our wonderful guests who've been on the show over the past couple of weeks. We really appreciate your support. We do have dry spells of episodes where you go a couple of weeks, we get a big haul of really interesting atypical cases. And then sometimes we get some dry spells. It's really nice to have listeners willing to come on the show and kind of pour some water on the arid landscape of our podcast to keep it going. So thank you again. Mike, how you doing?
I'm great. I'm really excited to be hearing about a case. And it makes it sound like if we didn't have all these guest episodes, you'd think that our lives were much less interesting than we make them sound on here. We really do have plenty of weeks of COPD exacerbations and heart failure exacerbations. So not every case leads to an episode, but we appreciate the guests giving the illusion that it is like that. So yeah. Ready when you are.
Let's do it, friend. You're going to love this one. So this is the case of a 70-year-old woman with small cell carcinoma of the lung that's in remission, DVT on rivaroxaban, and non-insulin dependent diabetes. She presented for over a week of global fatigue and sensation of feeling very sleepy during the day. She's not noticed any sore throat, cough, sinus pain, abdominal pain, dysuria, rash, nausea, or diarrhea. She said she's confused because she's been drinking plenty of water and Gatorade, and her appetite has only been slightly less than usual. The only thing she has noticed is that her blood sugars have been intermittently up to the 400s on repeat checks, and that's pretty high for her. Her initial vitals were showing no fever, a blood pressure of 150 systolics to 170s, over 90 to 110s. A heart rate was in the 90s, and she was saturating greater than 94% on room air. So the last time she saw oncology was 3 months prior for a surveillance visit. Because this is the most complex medical problem she has, I'll tell you a bit more about that history before asking you to comment on her chief concern. So the small cell was diagnosed a few years prior to this presentation, originally stage 3 of the right lower lobe, for which she received definitive chemo radiation. But this was followed by recurrence, and she underwent salvage radiation to the area, followed by immunotherapy. And the immunotherapy was ultimately discontinued due to immune checkpoint hepatitis and arthritis. But she's been in remission since, with the last CT torso occurring a few months ago, showing no mets in the belly and no progression of the known lung disease. But yeah, she's coming in just really, really tired, Mike. And I'm curious, before you have labs or anything, how you'd kind of tackle that.
Well, I think that everybody is rightfully overwhelmed by the complaint of fatigue, particularly when the complaint of fatigue is the complaint and it's not sort of elicited in the ROS where you're seeing them for something else. So if you feel overwhelmed, that's okay. It means that you're thinking broad. And I'll say that, I feel overwhelmed as well, because usually it could be anything on these podcasts, but I think we can just work through it together here. The most important way to think through fatigue is, I think, first and foremost, is this something that's physiologic or is this a secondary? And then even before that, figuring out what does this person mean by fatigue, right? I think it's similar to someone saying dizziness, right? It's a sort of a very large umbrella, and you want to try to figure out, kind of refine what you're really going to attack here as the differential or as the problem. For her, I think you would start the same way as everyone else, right? So you're going to still ask those things about physiologic causes. So asking about just sleep disturbances. Is this person sleeping enough? If this is more of a chronic issue, then could they have something like sleep apnea or other sleep disorders? What I'm hearing is, Andrew, that this is relatively acute. I just want to clarify the timeline on this.
Yeah, it was a little bit more than a week, maybe like 1.5 weeks. So she just feels really wiped.
Okay. Yeah. So, the second most important thing probably is going to be the duration, right, for fatigue. So, something that comes on relatively quick, like over a week, 2 weeks, it's either going to be some acute change in their life that's led to sleep deprivation, or sort of an evolving mood disorder, adjustment disorder, using a substance that they weren't using before, or change in medications. Those can be the things that physiologically lead to just sleep deprivation. Then you're appropriately sleepy. But more often than not, when just true of anything, right? True of any symptom, when there's less duration to it, when you're seeing them much earlier on, then it's much more likely that there's some other process that's also kind of acute, right? And this is secondary to that. So for her, she's got past medical history that certainly would make me have to cast a wider net, I think. I'd still be asking her the questions about mood, sleep, appetite, exercise. She's exercising a lot more than usual. I try to figure out whether or not she's feeling more short of breath or more weak when standing. Sort of trying to get a descriptor of what fatigue really means to her. I think those are important things. The big picture, though, here, I will be honest, is that in someone who's 70, has diabetes, has had blood sugars running high for a while now, and has a history of cancer, I think that you pretty much, for her, it's warranted to just get sort of the basic laboratory workup, right? So anemia, really common cause. Iron deficiency, even without anemia, is common. If you have some sort of smoldering infection, right, that's also can be common. If someone's been sick for, had this symptom for a week, could it be some sort of viral illness? Absolutely, right? So mentioned no sore throat, but you're looking for those constitutional symptoms. The presence of a fever is hugely helpful if someone is describing fatigue, right? Because most of the things I mentioned with physiologic fatigue, there's no inflammatory process to any of that. So if you've got a fever, that drastically changes things. Then also in terms of the chemistries, right? I really should, I think, have just basic chemistries, liver profile, and lights, which include calcium and phosphate, because I think that you can easily imagine where aberrations in any of these could lead to, or could suggest syndromes that would present with fatigue, right? Usually, a thyroid TSH is pretty much always warranted. I'd say it's such a cheap test and it's so easy to miss and so easy to catch. She has had checkpoint inhibitor in the past and had specifically complications of that. So I think it's definitely worth ruling out. Thyroiditis, it can happen at any point, right? You can get these immune checkpoint inhibitor complications at any point after exposure, not just right away. And could she have pituitary, HPA axis sort of issues from that? Certainly, right? So she could have issues with her adrenals. She could have issues with her pituitary, hypocortisol, right? That clearly makes you feel tired, right? And a lot of those things, fatigue is a very subtle finding sometimes. It maybe precedes other more obvious findings in disease processes. So I think you may be catching things earlier. Maybe if she didn't see a doctor for another 2 months, then this syndrome would become much more obvious, but we're catching her early on. So the cardiopulmonary thing is the other thing. And that's, I think you would elicit that on history, right? You're trying to, is this person short of breath? Is this person got dyspnea on exertion? Because any of those sort of anginal syndromes, pulmonary hypertension, those things can all present with this fatigue. So, but I think for her, I would ask some of those questions I asked and then get the labs I mentioned and let the labs sort of guide me. And of course, if there's an exam finding or a history answer that narrows things, then chase that as well.
That's so cool. I love how far you can take it before blood work. I think really getting as much of a description as possible out of fatigue could take you very far. So I'll give you answers to kind of everything you asked for. And then I guess the listeners can take a moment and think, are the labs going to be abnormal or normal after everything I said? So she has been sleeping fine I'll just say that she hasn't been observed waking up in the middle of the night with like apneic episodes or anything like that. Hasn't described any insomnia. And yeah, really nothing kind of like localizing. She really is coming in with this like pure kind of fatigue syndrome. The only thing being her appetite just being a little bit poor than usual. But again, she says she's been hydrating kind of excellently at home through this. So, okay, now I'll give you the labs. And I'll give you a second to write this stuff down too, because the labs kind of tell the story of this case. So the listeners too. I don't know if you want to jot this down or just take note of all of this. This is going to be kind of the big pivot. So sodium 132, potassium 2.7, chloride 83, bicarb 36, BUN 32. Creatinine 0.9 from a baseline of 0.6, so qualifying as AKI. VBG was acquired, pH 7.47, and PCO2 of 53. Glucose was 420, and A1C was up from prior at 8.5%. And LFTs showed a low grade transaminosis and alkaline phosphatase, but these are both known elevations from the immune checkpoint hepatitis I mentioned earlier, and this was notably confirmed by liver biopsy. And you take a look back, and the LFTs have been fluctuating like for over a year now. CBC showed leukocytosis to 14.4 with 89% neutrophils. There was stable microcytic anemia to hemoglobin of 9.2. And then you look into the reason for the anemia and see that she's had iron deficiency on recent outpatient labs. And a month prior, actually, she got a colonoscopy for this iron deficiency, and it showed a single adenomatous appearing mass measuring 5 centimeters in the ileocecal valve covering the whole circumference. And it was felt to be too large to excise and biopsy, so they left it alone. And the platelet count was normal on the CBC. So what do you think about those labs? Because it's honestly, it was one of those situations where, I don't know, based off what your history, what you were thinking was going to show up in the labs, but a lot of it was in the red, meaning like when you look at the EMR, you like look at the BMP, and a lot of it is kind of abnormal up front. So I'm curious what you think.
Yes, I would say that more red than blue. I just as always, I always want to make sure I'm not missing things over the microphone. So she had it was a large adenoma near the ileocecal valve on the C scope.
Yeah, the description, because I don't know how they kind of like describe these things on scopes that well, but I quoted it, adenomatous appearing mass.
Mass. They're calling it a mass. Okay. I don't know that I'll be able to tie it all in together, but at least I wanted to make sure I had the data. Okay, so yeah, you got a lot to bite into here. I don't know that any of these things were values I was expecting. I mean, most obviously in terms of how you could directly lead one to the other, she's got fatigue and your potassium's low. I suppose, that would be the thing that if nothing else was wrong, then you could say, okay, whatever. But clearly that's not the case. And clearly that, what I'm thinking is that she probably has a couple of things here, but my guess is that one process is probably pulling a lot of these electrolytes in different directions. And I think maybe I'm going to start with the chemistries first, and then I'll kind of play around with the other labs as I go, as my thinking. And I think the reason my eyes are drawn to the chemistry to start is, anytime you see the potassium, I guess so quickly, I'm not hearing that there's any GI losses that would explain her hypokalemia or, a contraction alkalosis per se. I'm not hearing that she's on diuretic therapy. And, I'm hearing that she's eating and drinking okay. So I don't think we have any reason to think that she's either losing losing chloride and bicarb, or not keeping up with some sort of insensible loss. So anytime you see the bicarb rise with the potassium falling, really whenever they're going in opposite directions, then you need to sort of just think about whether or not there's an issue of aldosterone involved, because, right, that's sort of when we think about hyperaldosteronism, right, one of the ways it presents is that you get a, hypokalemia, and you can get much less commonly, but you can get an alkalosis as well. And then, vice versa, right? A hypoaldosteronism, oftentimes you have a hyperkalemia, and a non-anaget metabolic acidosis. So what I'm seeing here is that that's just the first thing, that those things are moving in opposite directions, and I'm not hearing a strong explanation for each of those values independent of the other, which makes me think maybe that they're running together. She's mildly hyponatremic, but I don't know that that's actually real. I think it's probably just corrects with the glucose, and so I'm going to kind of ignore that value. And the glucose is also interesting. So I'm going to guess that there's not been any changes in her medications. There's still good adherence to her insulin regimen or whatever her oral hypoglycemic meds are. Okay. Andrew's nodding. So that's not, we can't explain it by that.
Could that have something to do with cortisol? I suppose. And so
I think then I'm going to come to the white count, right? So she has a mild leukocytosis. We oftentimes, the first sign of some sort of brewing infection can be, your glucose suddenly becomes poorly controlled, right? We see that in the hospital all the time. It can be the first sign in the hospital, right? And also we see it, right? It's why people who, they have infections, it's one of the I's for DKA, right? So we know that it causes sort of this, hypercortisol response that can lead to hyperglycemia. So, that's, I suppose, a thought there. And then the anemia, I don't know. I don't know that I'm gonna latch onto that quite so much right now, because we have a potential explanation for it, which maybe there's this mass in the colon. And I think overall, I'm drawn to that as, as a possible etiology for some of these things. Although I think I have to think more about what it could be and then what it would do to cause these things. But that's like, if someone had iron deficiency anemia, you would go looking, we have found something that has not been addressed, right? So that diagnosis is still at least partially explained by that. And, I think the other thing, the VBG, so she was a little bit alkalotic on it, 747, but then the CO2 was 53, is that correct?
Yeah, that's right.
Yeah, so that's a little interesting too, right? Because I was expecting just a pure metabolic alkalosis, and then she would have a compensatory respiratory acidosis, right? But CO2 is higher than I would expect. She's. It makes me wonder: is she compensating for something respiratory wise with her bicarb rather than the other way around? So I'm gonna pause for a second here and just try to digest things.
Yeah. And Mike, I could just interrupt and say, I think this lab pattern we don't see super often. So, and as you said, a lot of different things can cause this sort of picture. If there's like occult losses, volume losses, if there's occult infection, like you said. So I guess just, with the knowledge, you don't need to solve this on like day one. What would you kind of do to start kind of exonerating the common things? I guess just what we do in general to kind of get to the final answer eventually, but maybe not today, day one.
I think what I'm hearing, Andrew, is that there's really not much on exam. I think, of course, that's the first place to start here, right? Is there anything infectious that we can find? Anything that localizes? It sounds like nothing on history. That would be the first thing, right? Just make sure that she doesn't have some sort of infection.
Yeah, no, none of that. But I can certainly give you the workup, because I'll just say the team that admitted this patient wanted an explanation for the leukocytosis, so I can definitely give you some workup for.
Yeah, I probably should get like a respiratory viral panel, and she didn't fever, so I'm not sure I'm getting blood cultures on her. If she's had any sort of UTI symptoms, you're getting a urinalysis, a chest X-ray if she has a cough, but. I try not to overly medicalize someone if they just have a lab value, particularly if I don't have a strong pretest for a lot of things. Yeah, I guess I'm interested to hear what they would want.
Yeah, yeah. Because
I don't know. Not a lot to bite my teeth into in terms of infection, though.
yeah. I'll give you what was acquired. So UA, 24 white cells. It did reflex culture to something greater than 100,000 Streptococcus or Lactobacillus species. Very, very weird. Like these are like, contaminants, not really pathogens as far as I know. RVP negative. Chest X-ray was read as having no focal alveolar infiltrates. Abdominal ultrasound showed no evidence of acute hepatobiliary disease. And then, due to the leukocytosis on admission, she was put on ceftriaxone. Due to the AKI, she was given isotonic fluids. Her prerenal azotemia returned to normal over 2 days, but her hypokalemia remained pretty stubborn when you look at it. The potassium stayed in the 3.2 to 3.3 range despite supplementation. Her bicarb improved from 36, but is still 28 to 30. Her glucose has remained in the 300 to 500 range, and the leukocytosis has continued. And actually, when you're meeting her 5 days into admission, the white count is actually higher, now at 13.4. Blood culture sent on admission, negative. Her blood pressures have been increasing throughout admission, with the only new symptom occurring while inpatient being what she calls a migraine. And to give you some numbers, her systolics have been in the 170 to 190 range. So given the headache, she was put on labetalol with ongoing systolic blood pressures in the 150 to 170 range. And I'll pause there.
Okay, so I'm going to ignore the urine culture. Hopefully that's okay. But yeah, as we, I don't know. I don't know if we can really say that she responded to ceftriaxone. She got fluids, and she seems to have responded to that. Maybe, at least, maybe partial of that metabolic alkalosis was like saline responsive, possibly, but not entirely, because her bicarb is still relatively high. And if we think that the potassium is related to some sort of aldosterone system issue, then it hasn't really been fixed with the fluids necessarily. I don't know that I want to continue to march down the leukocytosis path at the moment. And the reason is because I'm worried that if I do that, I'll ignore other things. And since she's still not giving us an infectious phenotype, right? Infections generally declare themselves. And so, you want to keep them in the back of your head always. You don't want to miss things, right? But if she got a fever, that changes things, right? If she develops some sort of localizing symptom, that changes things. But sometimes it's, okay, I'm acknowledging the white count, not ignoring it, but I'm going to go look for other things, and we'll see if the things I'm finding or looking for eventually overlap with an illness script that would include a leukocytosis. So not ignoring it, but putting it off to the side for a moment. Hard to ignore, right? I sort of mentioned the aldosterone system being an issue, and then I'm hearing in this aliquot that the blood pressures, which were high on admission, are now more of an issue. They're having to be addressed in the hospital. Someone felt that they needed to have labetalol, which suggests that they're getting calls about it and pages about it. So that is kind of classic hyperaldosteronism, right? It's kind of a refractory hypertension with hypokalemia and alkalemia, although not necessarily to the degree that the hypokalemia presents. Oftentimes it's the potassium. What I'm sort of wondering is, and she has an ultrasound of her just her liver, correct? It was an abdominal ultrasound. Or did it also include like the kidneys as well?
Are you asking for a renal artery diameter, Mike?
I think that just like in general, right? Like, so, in young people, it's going to be primary hyperaldosteronism. But as we get older, then we worry about other things that cause this. And it's going to be renal artery stenosis, adenomas in the adrenals, adrenal hyperplasia, and, just like kidney pathology, I sort of think about. I think that like renal cell carcinoma could do this, or if you actually just like compress the kidney enough, it gets angry and starts to do this. So Like if someone falls and they get like a hematoma inside their renal capsule, they'll get hyperaldosteronism. Usually they're not coming in with the potassium; they're coming in because they fell and they're bleeding into their kidney. But I think you can see that as well. Has a fun name that I can't remember at the moment. But so yeah, I just feel like I'd like to characterize that. I'd probably get a urinary chloride, because if the person's dumping chloride versus if they're retaining chloride, that can help you in terms of what's causing the alkalosis. Although that's gotten better, it seems like. My guess is that some of it at least was chloride responsive, the saline responsive. And then I think I'd probably, is the renin and the aldosterone levels high? Like, I don't know if that comes back fast enough. Wherever this patient is being seen, I actually didn't even remember what context this was in, but yeah, I think it'd be good to see that as well. But yeah, so I'm going to say urinary imaging, or excuse me, renal imaging of some sort. Then if we can get a urinary chloride, great. If we can't, that's okay. And then renin and aldosterone ratios, if it's possible, if that's available, just because that's the signal I think that we're getting right now. I think I'm going to stop there. Hear what you have to say. It doesn't necessarily account for the leukocytosis at all, and I appreciate that, but I'm going to follow this whole, and then we'll see if it loops back around with any other Venn diagrams here.
Yeah, this is a lot of fun to hear your thoughts. I'm rearranging the final bits of information I'm gonna give you because I think it'll be more fun this way.
I don't know if that's a good sign or a bad sign, but
so just to answer your question quickly though, well actually no, this aliquot will actually give you this. So as you remember, the LFTs were high, likely from immune checkpoint toxicity, but in the absence of anything else, Zavin talked about in his grand round, he had to play medicine more like poker rather than chess. We were like, we think this is something metabolic, but who knows? What if there's something hiding in the liver that we're not seeing here? And this is like FUO without a fever. So we were like, we should CT the abdomen. We already had the test that would clinch the diagnosis cooking, but in the background, we were like, we wouldn't want to miss that. So we got a CT abdomen pelvis with IV contrast. And I'll just say, no like renal artery stenosis. The kidneys look fine. There was no hepatic abscess driving those LFTs. It showed the ileocecal mass that we knew about from the colonoscopy, but there were also multiple enhancing retroperitoneal masses that were new, as well as 2 new left adrenal nodules with varying attenuations. And this typically takes several days to come back, but I'll give you what you asked for. Aldosterone was deeply suppressed. Renin was elevated. And that'll be the last aliquot before I give you the reveal. I didn't bring the actual absolute number for renin, but it ends up not mattering since the aldose.
Yeah, I don't know that I would have. I don't think I look at that number enough for it to be me. High is good enough. Very high is helpful for me. So, honestly, I feel like this is this sounds like something that's hyperrenin secreting, right? That's what's. The aldosterone, I imagine, is suppressed appropriately because the renin is being hypersecreted. She has findings in her adrenals, and she has, a mass in her colon. In addition to, you said that in the retroperitoneal space is there are lesions. What were they described as again?
Yeah, the report said multiple enhancing retroperitoneal masses.
Masses. Yeah, and they're not lymph nodes. It's not lymphadenopathy. It's mass.
Yeah, it doesn't distinguish. It just says masses. Yeah, I guess I'll pose the question to you because the renin is high, and again, I didn't say how high, but if the renin is high but the aldo is really low, like can these findings in themselves explain these findings? Because the aldo being high, you just told us the aldo being high would mean you would have the skewed findings, the metabolic alkalosis and the hypokalemia. Oh yeah, what do you think?
Yeah, it's a good point. It's like the thing I was not expecting to find. It was sort of like the aldo's going to be high. Let's see what the renin is. But this was not the finding I was prepared for. So, What I'm struggling with here is a gap in knowledge between what aldosterone versus renin can do, and if the renin by itself can do the same things. Because I think about them oftentimes working in concert. So
Yeah. I'll say I'll try and get you there and say, renin can't do these things. So something is driving the aldo to be low, because renin is high, aldo should be high too, but it's low. So it's a bit of a paradox, and something is causing the body to behave like there's aldo around. Like you're absolutely right. The aldo should be high, but it's not. It's low. So something is causing the body to perceive aldo being there, and renin can't do it, to answer your question. So you're right. You were right. None of your clinical reasoning is wrong here.
Yeah, so that was a good summary, I think. Yeah, I think the help I definitely needed was to, I wanted to be sure that renin couldn't do these things as well, and I didn't have my pathways backwards, but sounds like no. So I'll be honest, I am drawing a bit of a blank here on how to connect all these things together. Either a hyperrenin state or something that's excreting renin, and then also have these other findings. And so I think maybe what I need to do is I need to just go back to the initial labs and the labs here, because I think that maybe I found myself anchoring here. So
Oh yeah. I was gonna say, and I'll even give you just like to summarize the kind of the relevant lab pattern again, and the listeners can also kind of think, if this was on a board exam and you saw these things together, would this like ring a bell in any way? And you commented on all these things. Yeah, hypokalemia, metabolic alkalosis, hyperglycemia, and hypertension. Those are really and you said all of these things.
right, and I mean, hyperglycemia, hypertension, right, Cushing syndrome, and mineralocorticoid excess. We have a CT scan that shows the things it shows, but nothing else. So what I'm going to do here maybe is just think about is there anything I can ask for, at least just to help clarify maybe a rule-in sort of test. I'd probably have to get some sort of tissue biopsy of this mass if we don't. I guess it was like they had a colonoscopy. I don't know that I heard pathology from it though.
Yeah, they didn't excise it because it was too big.
And they didn't even take like a little biopsy of it. They didn't do.
No. Yeah.
Okay.
I don't know the rationale why. I'll give you tissue though, Mike. I'll give you tissue.
Yeah. Because I think that at this point, I don't know that I'm gonna. I think I'm just gonna run myself around here in circles. And so sometimes when we don't have an illness script and we don't have an idea of what's going on, sometimes it's like, well, I see pathology there. Let me sample that pathology and see if it generates anything new. That would be my authentic approach here. But no, I'm pretty stumped.
Well, I'm glad I brought the case. Hopefully I stumped some listeners too. To be honest, the story of this patient was really occurring before I came on service, like over the weekend when the hypertension was happening and the labatable was started. And, all of the relevant labs you needed for this case were available on day one. But recognizing it in real life is tough if you've never seen it before, and that's kind of what we're seeing with your discussion. Nobody on the team had ever seen this before. They actually kind of framed this as a secondary hypertension case, as you did, and just sent like all of the blood work you would get for that, like serum catecholamine screen. Not great, listeners. We won't go into that. They sent that. They sent the renin and the aldo that I already gave you, but they also sent, not really thinking too much that this could fit that well, but gave us the final answer. They also sent a random serum cortisol that was 182, the upper limit being 20. ACTH ended up coming back greatly elevated to 361, the upper limit being 50. She underwent chest imaging, next showing an enlarging right thyroid nodule with likely metastatic lymph nodes in the chest. Biopsies of a cervical lymph node and retroperitoneal mass both demonstrated METs of her small cell carcinoma, confirming progression of small cell lung carcinoma as the culprit of ectopic Cushing syndrome. For treatment of her hypercortisolism, she was put on metyrapone, which inhibits the enzyme 11-beta hydroxylase and therefore the synthesis of cortisol. And then during the 2 weeks, she remained inpatient for initiation of carboplatin and etoposide. Her glucose is improved to the 100 to 200 range. Her hypokalemia resolved and her bicarb returned to 25. Her leukocytosis and neutrophilia also resolved. So, quick facts on small cell lung cancer. It comprises about 15% of all lung cancers diagnosed in the US. It's known for not only its rapid rate of proliferation and propensity to metastasize early in its disease course, but also for its propensity to cause paraneoplastic effects due to the neuroendocrine nature of the disease. While paraneoplastic complications are certainly inherently morbid, they actually do provide an advantage to the diagnostician who is aware of the presence of this, because these effects can result irrespective of the size of the underlying culprit cancer. And this honestly goes back to our kind of cryptic cancer schema that I whipped up and spent way too many hours on after Austin's case. In other words, very small, even microscopic tumors can cause these effects. And identification of these syndromes before subsequent metastasis, of course, carries a better prognosis for the patient because the disease may still be very localized to the chest. And notably, this patient already had small cell lung cancers. And when I was reading on this, these paraneoplastic effects can kind of be the very first sign of tumor progression. So they need not be present up front. So your tumor can change over time. And this was kind of the very first signal that this patient's disease was progressing. So just on paraneoplastic syndromes in general, it describes ectopic production of some biologically active hormone or antibody. In small cell, the two most common syndromes are SIADH and Cushing's. Much more rarely, neurologic syndromes can come in the form of onconeural antibody-mediated diseases, like that seen in anti-WHO antibody disease, and this can cause limbic encephalitis, cerebellar degeneration, and polyneuropathy. And this was actually apparently the first onconeural antibody discovered, but more common than this is the paraneoplastic Lambert-Eaton syndrome, and this is from anti-voltage-gated calcium channel antibodies. And then just really quick, so on secondary hypertension, which Mike already talked about a little bit, it should be suspected if there's hypertensive emergency, resistant or labile hypertension requiring 3 or more drugs to control, age less than 30, or as in this case, associated electrolyte disturbances with the observation of an exaggerated hypokalemia and exaggerated metabolic alkalosis response to diuretics, kind of being the classic tip-off for hyperaldosteronism. But really, I think more broadly, that just represents, with diuretics, you're kind of iatrogenically making someone like volume depleted. Really, anybody having any form of volume depletion, you can witness this phenomenon with hyperaldosteronism. And as we just learned in this case, which fooled Mike and hopefully some listeners, Cushing syndrome can do this too. So basically, the mechanism of Cushing's looking like hyperaldosteronism is there can be so much cortisol around in ectopic Cushing's that in the kidney, the degradation enzyme for cortisol is just flooded. So there will still be cortisol around that will just overwhelm that enzyme, and therefore there's a surplus of cortisol. The cortisol typically doesn't bind to the mineralocorticoid receptor that much because it gets degraded. But in this case, it actually hops onto the mineralocorticoid receptor or aldose receptor, and it behaves just like aldosterone. So basically, it's a mimicker of hyperaldosteronism. And of course, in the setting of this patient's cancer, which we now know has this propensity to have paraneoplastic effects, we know that Cushing's is kind of associated with that, and that's kind of how we tied everything together. But yeah, what's your reaction? What do you think?
Well, I think the thing that you may have just answered it there, but I think the thing that threw me was my understanding was that in Cushing syndrome, yes, the aldosterone's low, but also the renin is low too, and I think that is probably the thing that threw me the most right at the end there. I think I was maybe relying on that renin-aldo test as almost like the clincher. And when it did not give me the result I was expecting, I'll be honest, I sort of just threw out Cushing's then because it didn't give me that thing that I was expecting. So I think that's something that I need to read a little bit more about. Is so what I'm hearing is that just the degree of cortisol, like the actual serum level, is basically just mimicking aldosterone.
I think the thing is that I'm having a hard time understanding why the renin wouldn't be suppressed. I think that's like that's what's throwing me for the loop.
No, you're spot on. And then hopefully other people got fooled by that too, because if you go to the textbook, it should be low. So I don't know. I don't know why the renin is high here. But the value in those two tests I gave you is you were expecting a very high aldo and it was actually low. So we kind of had to ignore that. But you're absolutely right. According to the textbook, the renin should be low.
The fact that the Cushing, the cortisol, itself can essentially just behave as aldosterone in terms of the downstream effects. That's 100% a learning point for me. And it's just another good example of that, if the receptor's triggered, the downstream effects occur. Doesn't need not be the thing that's supposed to trigger that receptor, right? So, and that's exactly what happens in paraneoplastic syndromes often, right? Is that you have something that's mimicking. And in this case, it's actually just the fact that the cortisol itself is so super physiologic that it's attaching to this receptor. So that's a really interesting point, but a great initial presentation. Cause yes, absolutely. Looking at that, you could, leukocytosis, hyperglycemia, hypertension. That sounds pretty Cushingoid. I didn't hear, body habitus because it hadn't been enough time, right? This happened over just probably a couple weeks. And so that was missing from my illness script. And I also think in general, I think of Cushing syndrome as something that's more chronic. I don't know that I see it in the first week or two of presentation, but, when you throw in the fact that this is likely due to an explosive recurrence of cancer, and small cell makes a lot of bad stuff. It's kind of like you said, the preeminent paraneoplastic creator. So I have a lot of reading to do in endocrine after this. So thank you, Andrew. I really appreciate this case. It puzzled me.
Yeah, for sure. And I'll leave you one other caveat, because there is like one other weird thing to this case. Not all Cushing's looks exactly like this. So hypercortisolism mimicking hyperaldosteronism, really the one group of hypercortisolism endpoint diagnoses that can do this are the ectopic hypercortisolism diseases, really cancer. These cancers can secrete so much ACTH and drive the cortisol so high that it causes this hyperaldo mimic that we kind of talked about. You really need that much cortisol to flood that degradation enzyme in order for that binding to happen and to cause the metabolic alkalosis and hypokalemia. Not all Cushing's phenotypes will do this. So like central ACTH production from like adenomas in the brain. These things generally don't do this as much. So actually that in itself was kind of a clue. If you just like look at the initial labs and you say, oh, like hypercortisolism, but then you see the prominent kind of hyperaldo phenotype, you can even take it a step further and say, okay, there's actually probably ectopic ACTH production. And then you look at the metastases on the scan and this patient has small cell, you're like, oh, okay, this like has to kind of come back positive. Like this is the best fits. But yeah, thanks again for discussing, Mike. I know it was a lot of labs in the red to look at. Appreciate you playing along as always.
Thank you. Thanks for letting me play along. It was a lot of fun. So thank you, Andrew, as always.
Yeah, take it easy, guys.
This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.